بسم الله الرحمن الرحيم. أنا الدكتور عمرو خيري، رئيس قسم العظام جامعة عين شمس. Dear colleagues and friends, it gives me a great pleasure to welcome you in the inauguration of Ain Shams orthopedic platform for series of webinars. All the time of pandemic, lockdown, and social distancing, online education became apparently of great importance to interact and continue our educational tasks. This project we are starting today in our first webinar aim at presenting structured educational activities in all subspecialties of orthopedic surgery, and to interact and enjoy our talented surgeons and lecturers of Ain Shams staff. Ain Shams University, founded in 1950, has been contributing to the training and graduation of generations of orthopedic surgeons, plus our collaboration with almost all international societies and universities all over the world. We hope that this effort creates interest and start interaction and discussion, enriching our knowledge, understanding, and exchanging worldwide experiences among surgeons. We have chosen to start our first webinar in arthroplasty as an extension to our famous old Ain Shams Arthro Club, which was founded by Professor Taimur, who is with us in the panel today, and Professor Sawai, and was joined with me later. This Arthro Club has spent over 10 years in teaching and discussing all problems of the hip and knee surgery, and succeeded to create a strong generation of arthroplasty surgeons, not only in Ain Shams, but all over the country. We aim to perform serial webinars on a weekly basis with subspecialty every week. Next week, we'll have one with arthroscopy, the after coming week with pediatric, all interesting, and all will be on Monday at 9 p.m. And so, I hand the microphone to our chairman, Professor Zahir Hassan Zahir, to start our first webinar. Thank you very much. Fadal, Dr. Zahir.
Thank you, Dr. Amr, for the introduction, and thank you for the initiative you have done for our department. Today, we are going to start our first webinar. It will be about arthroplasty, and as we all know now, we are in the era of revision total hips and revision arthroplasty, and we start to forget about how to do it right primary. So we need to start from the beginning with the how to do a perfect hip, a total hip. So the main target of this webinar is about primary total hip, some tips, some tricks, and I have the pleasure to introduce to you our very respectable panelists, whether international and local. So we have with us, I have the pleasure to introduce to you Dr. Klauser from Germany. He is an arthroplasty surgeon, and he's very famous in total hip and total knee arthroplasty, and as I have known that he is very famous in revisions and septic hips. Also, I have the pleasure to introduce the founder of the Arthro Club, which is Dr. Professor Taimur Al-Husseini, and he is one of our famous arthroplasty surgeon. And also in the panelist, Dr. Amr Khairi, the chairperson of our department, and he's one of the pioneers in the arthroplasty and total hip replacement. Also, this session will be moderated by Professor Ibrahim Ganzouri, who is a professor in Ain Shams University, and we are going to present two sessions. First session will be presented by Dr. Ahmed Salim. It will be about mainly about how to do the proper alignments of the hip and how to do the proper templating. And the second session will be about how to choose the proper hip for special situation or for each situation. And it will be presented by first session will be presented by Dr. Ahmed Salim, and the second session will be presented by Dr. Haitham Abdulaziz. So I will give the mic now to the moderator of this session, and Dr. Ibrahim Ganzouri. Please, Dr. Ibrahim.
Hello, everyone. I'm really happy that we're starting our ancients series of webinars, as Dr. Amr was saying. And today you have a very interesting, hopefully a very interesting discussion. It's all case-based webinars or case-based discussion where Dr. Salim is going to present few cases upon which the panel will comment and discuss these cases. This is followed by maybe a question and answer. Then Dr. Haitham Abdazim will present another few cases also that will be discussed through the panel. So would you please, Professor Dr. Salim, share your screen?
Thanks, Dr. Ibrahim, and thanks, Professor Amr and Professor Zahir and all panelists. We all are looking for ideal total hip arthroplasty, aiming for good function for the patient, stable implant, and pain-free joint. I'll present the first case. This is a male patient, 22 years old, with ankylosing spondylitis.
Sorry, Dr. Ahmed. Dr. Taimur, please, would all the panel put the video on? Dr. Amr, Dr. Taimur, and Dr. Klauser, please, so we can interact together. Sorry for the interruption. Dr. please go ahead.
Raise the hand. Please deal with this. Raise the hand, Aisawi or Dr. Ibrahim.
Go ahead, Salim.
I have on my screen, Ahmed Sufi. Okay.
This is our first case presented. Male patient, 22 years old, with ankylosing spondylitis affecting both hips. He was scheduled for a total hip arthroplasty for the right side. And this is our X-ray post-operative. So I'd like to ask the panelists about their opinion about this post-operative X-ray.
So should we start by Dr. Taimur? Do you have any comments regarding this X-ray, regarding the position of the hip, or anything you would like to comment on?
Yes. We have things related to the positioning, definitely. Talking about the acetabulum, there seems to be an abnormal antiversion. It's probably in antiversion, but it could be as well in retroversion. You don't see the equator of the cup, although in this particular X-ray, to comment on the version of the cup, you should actually have the pelvis set in the anatomical position. This pelvis is a sort of, you could see that the obturator foramina are both very widely open. So this pelvis is inclined in a way to disrupt the readings of the acetabulum a little bit. Nevertheless, I think, although with this tilted, forward tilted pelvis, we have an antiverted cup. The stem has two failures in my view. The first one, very obvious, is that it's set into a varus position. The tip of the prosthesis, the lower tip of the prosthesis is touching the lateral cortex, while the vertical axis of the prosthesis, both on the medial and the lateral borders of it, are far away from the axis of the intramedullary canal.
So, sir, you mean that the position of the stem is in varus?
The position of the stem is in varus, yes.
Okay.
Provided that this is a fresh X-ray.
Okay. And you're suspecting that we have a problem related to the antiversion of the acetabulum?
Yes, there is also a problem with the size of the femoral stem. It seems that this is a cementless, to my view, this is a cementless stem, which is far smaller than the supposed to be size of this stem, which should at least have some fitting in the proximal 2 or 3 inches of the femur. Nevertheless, there is one good thing about this hip, is that the calcar cut is high, as you could see. the surgeon have cut the neck in a high calcar cut position, which is a right thing to do in this valgus hip. Maybe in the forthcoming talk, Professor Ahmed Salim will tell us about it. But I will summarize, despite the abnormal position of the pelvis, this is an anteverted cup. This is a small stem which is set into a varus position. That's my opinion.
Klauser. Thank you, Dr. Taimur. Dr. Klauser, Dr. Taimur was saying that this is a high cut, high neck cut. And maybe that's one of the causes of the varus stem, because maybe the surgeon was not able to get the stem in. Would you like to comment on that?
I think a lot of what has been said was very right, and I would agree to that. I think that, I mean, what really I find astonishing that this patient is only 22 years old. So this is a very young patient. And I think what is important to remember is that we need to actually, especially in those young patients, make sure that we get the best possible position, the best materials, because what we want to achieve in this procedure is longevity for the patient. He's very young, he's very active, so his demands are going to be very high. I agree that there is a high cut on the femur, leaving a lot of the calcar remaining there. But then keep in mind that if you look at the opposite hip, there is a big offset there. And maybe the surgeon tried to do that purposely in order to restore the offset by mechanically speaking. Having said that, I think that the position is far away from being ideal. And I definitely think that this femur component probably is completely understuffed, too small for the femur.
So would you think that this undersizing of the femoral component and this varus position might affect the longevity of the implants?
I definitely do, yes.
Okay. Dr. Amr, thank you. Do you have any comments regarding the position of the X-ray or anything?
I think my comment on this case is that we always ask all our students to retain the neck, because the presence of the neck will restore the rotational stability and gives longevity to our implant. However, this makes the entry of the implant in such a way, so the surgeon must be very alert for his entry point, although he is retaining or keeping this neck. And if he found that retaining the neck cannot make him put it in a good position, he must go down with his cut. Anyway, retaining the neck is a good thing, but always try to restore a good entry point to avoid this varus position. This is my comments.
How can, okay, Dr. Taimur, how can we prevent or avoid such position of the stem? Do you think can you do anything? Maybe lower cut.
Yes, you can't do anything now about it, but it is my judgment that this stem was inserted far so medial in the way that we used to insert curved stems in the early years. This straight stem should enter the femoral canal more or less at the piriformis fossa area. As you could see,
would you care
as
to,
you could see.
Okay, so sorry. Okay,
can you hear me?
Yes, perfectly.
As you could see, the superior neck and the medial greater trochanteric knob is pristine. The surgeon did not touch this area, while this is the area that you should actually start your reaming and your broaching. So in this case, I think this is a technical mistake, inserting the femur of a straight stem with the wrong technique, not intended for this stem. And when you do that, you'll find yourself in a tight entrance. You're in a tight entrance proximally, while distally you are far away from the size of the femur, as you could see. But of course, at the operation, you don't see that. What you see is a difficult entry, and you're afraid to increase the broaching, so you will cause a crack or a fracture. So my comment here that this is a technical mistake, and the main culprit of this technical mistake is the insertion and the entry of the femoral component far medial than the supposed to be lateral position.
Dr. Amr, if you're planning to use a stem, let's say size 10 or 11, and you end it with size 9, and maybe you will be a little bit worried why you are going for a smaller size. Would you care to take an X-ray intraoperative or an image to make sure, or would you think this is a waste of time?
I think if there is any doubt, it's mandatory to have an X-ray, an image. It will save you a lot of troubles, either for the stapler side or for the femoral side.
So I think all the
don't be so confident. Try to make a perfect job, especially in such a young chap. So I think it's mandatory in such a case to spend 5 minutes and have an image intensifier shot.
Okay, thank you. Dr. Taimur, Dr. Placer, would you agree with Dr. Amr?
I definitely would agree. I mean, I think we all agree that this stem is probably not the ideal position and also not the ideal design for this kind of hip. I think that if you look at different designs, and we are going to talk about that later on, I think that there is better implants probably that are more appropriate for that kind of anatomy.
So let's assume that this is your case, Dr. Klauser, and you were happy with the case, and you took the patient to the X-ray, and oops, that was the X-ray. What would you do? Would you go for a revision, or you leave the patients?
That really depends on the clinic of the patient, isn't it? I mean, I would have a sleepless night in the beginning right away because I would be very unhappy with this X-ray. But apart from that, I think it is a very wise decision to have fluoro available at the time of surgery and then actually revise the stem on the table right away before you actually do an X-ray post-operatively. And you find yourself in that situation. I would let it go now and actually explain to the patient that maybe the result is suboptimal and that we hope for the best, but you have to counterbalance the risks of early revision in a situation like that with infection and so on and so on. If the patient is doing fine, then let it go and let it put him up an annual revisits in your clinic and see how he's doing. If you see that there is early failure, then I would rather do an early revision then instead of going back in right away.
Okay. Dr. Taimur, as Dr. Placer was saying, this is a 22 years old chap. Probably they have used a ceramic head or something like that. But I can see that this probably a 36 millimeter head. And probably this is a 52 or a 54 millimeter cup. Would you prefer to go for a 36 head on such a relatively small cup, a 50 or 52 cup? Maybe 54, I'm not sure. I'm not aware, but it looks like a 50, 52. Or would you go for a smaller head or something like that?
I really think that you've caught the grain on that. This is a too much far big head for this size of cup, for this type of patient, for this age of patient. He is a young chap, and he has lots of years to go on, and he needs a thicker poly, if I could say, a thicker poly for his cup than this one. The average advantage of a 36 millimeter cup as compared to smaller cups like say 32 or 28, definitely the 32 and 36, they don't have much fantastic catching concerning the stability. I wouldn't use a large head on a small cup like this in this young patient. Maybe in an older woman or an older man with a life expectancy and activity level less than this chap in front of us.
Okay. Final comments from the panel. Dr. Amr, would you like to have any other comments before we proceed?
Probably sometimes I use this large head in special situations. For example, I have a judo player. So I know that wear against versus stability. In some situation, you have to ask for stability. because this it was a young chap, and I know he will come. He'll go back for to keep the neck. Thank you.
Okay. So to sum up, the panel think this is a malpositioned stem, underside stem, maybe with a bit of antiversion of the cup or retroversion, as Dr. Taimur was saying. Though we cannot comment on these X-rays probably due to malpositioning of the pelvis, maybe a bit large head of a large head compared to the size of the acetabulum. I'm sure that Dr. Salim has got a lot to share with us. So would you please continue?
Okay, Dr. Ibrahim. So I see that the whole panel agree that there is malposition of these components of this hip. To sum up for critical appraisal for these X-rays, there are some comments about the view of the X-ray, the cup position, head size, stem position, and stem size. Okay, so the ideal anthroposterior view of the pelvis to judge X-ray post-operative for total hip, we have the pelvis to be centered and the X-ray beam centered over the symphysis pubis. And the ideal anthroposterior view will show us that the tip of the coccyx is superior to the symphysis, but not more than 2 centimeters. And this is not the situation here. So this is not true X-ray, not true AP view of the pelvis. It is a little bit related to the pathology of this patient. Most of the patients with ankylosing spondylitis, of course, they have problems in their spine, and the pelvis is tilted forward. So mostly there is difficulty in obtaining a good X-ray without tilting the beam of the X-ray. So it is nearer to be a pelvic outlet view. And with pelvic outlet view, the acetabulum usually facing more forward and more flexed. And so the cup appears to be more antiverted than usual. Mostly, this is not the true antiversion of this cup, but because of this malposition X-ray, it gives us the impression that it is very antiverted. The other point, all agree that the stem point of entry is too much medial, and this results in varus stem, and consequently, this results in undersizing because of breaching of the lateral cortex. And so there is resistance with breaching the femoral canal, and this, I think, one of the causes of undersizing of this stem. And this, of course, will affect the offset and increase the bending moment on the stem. And of course, it will affect the longevity of the implant. We can assess the antiversion in the anthroposterior view. According to Leo et al., one of the very reliable methods for measuring the antiversion using the formula of the longitudinal axis of the outer border of the femoral component of the acetabular component. We take the longitudinal axis, the most longitudinal axis of the ellipse, and another line perpendicular, and the angle in between. The formula states that we calculating the version by multiplying this angle by its 10, and this will give us an assumption about our antiversion. If we look for our X-ray for our patient, we'll find that, of course, this angle is too much increased, but again, this is maybe because of the malposition of the X-ray. And of course, the stem looks is going into varus, and this results in its malposition and undersize. Another view with that from which we can calculate the antiversion is the lateral view, cross-table lateral view, and one of the methods and reliable methods to calculate our femoral antiversion So combined lateral cross-table lateral view and anterior view may give an idea about the true anteversion of the cup. See, so this is the first case.
Ahmed,
Our
would
second.
would you please repeat how to calculate our version, maybe in Arabic, so we can all understand it?
The anteversion we can in the anteroposterior view.
بالعربي اشرحه بالعربي بعد اذنك.
In Arabic?
Yes, please. Just a bit, repeat what you were saying in English, but in Arabic, please.
Okay. We take X-ray pelvis anteroposterior view. The outer border.
أحمد ده إنجليزي.
الجزء الخارجي من الكاب احنا بنعمل lining for the outer border of the cup and we take وبناخد القطر الاكبر من الاليبس او اللي هو الكيرف اللي هو الشكل البيضاوي اللي هو بيمثل الكاب نتيجه ان هو محطوط في انتي فيرجن وبناخد another line the shorter diameter او القطر الاصغر بيبقى عمودي عليه ده بيكون لينا زاويه هذه الزاويه بناخد التان بتاعها وبنضربها في الزاويه دهيت ده هيدينا الانتي فيرجن بمعنى لو الزاويه دي 30 وبنضرب 30 في تان 30 بيدينا حوالي 17 او 18 ديجري انتي فيرجن معنى كده ان الكاب ده محطوط في انتي فيرجن حوالي 17 او 18 ديجري ده في الانتروبوستيريور فيو بالنسبه لللاترال فيو العيان بيتحط في كروس تيبل لاترال فيو ونتيجه وبناخد لاين horizontal and parallel to the cassette and another line is drawn perpendicular to it and a line at the outer the opening at the edge of the cup and this angle represents the anteversion. But with cross-table lateral view, mostly the other limb is flexed, and this may affect the flexion and the tilt of the pelvis. And to make sure that our measures are reliable and accepted, we take another line, which is the longitudinal axis of the ischium. It should be about 26 degrees. If it is around this reading, this figure, with the horizontal line, so our pelvis, we make sure that our pelvis is not too much tilted, so our reading will be reliable as a measure for anteversion. If this
then double check, we make check by the angle between the ischium and the horizontal line.
And the horizontal line.
That we are in the proper measurement. Okay.
Yes.
Thank you.
Our second case is female patient, 50 years old, has arthritis in the right hip, and she operated for total hip on the right side, and this is the X-ray post-operative. I'd like to listen for your comment, please.
You please, all the panel, please open, share the video, please. Videos, Dr. Klauser, Dr. Taimur, Dr. Amr. Okay, shall we start with the panel? Dr. Amr, would you like to comment?
Yes, of course. I think I have a comment on the orientation of the cup. I think this is a too much vertical cup. I think it's not seated on the teardrop, well seated, or it is seated, but still it's in a vertical position. I don't know why. Probably there is an osteophyte or some sort of a ridge. I don't know. And this is what I am saying, that reaming must be checked by an X-ray before doing our final seating of the cup. So this cup, there is no problem to have a well-oriented cup and have a part of the cup uncovered. There is no problem as long as this part does not exceed 20% of the cup. But to have this vertical position, it is very liable to dislocation, of course. So they have a problem with the orientation of the cup.
As I understand that you, sir, are taking X-ray in all of your patients or whenever in doubt? You're taking an image picture or an X-ray intra-op in most of the patients?
For the
Yes.
acetabulum, usually I have an X-ray and an image intensifier shot. Yes.
Okay, thank you, sir. So, Klaus, sir, do you do that, Dr. Amr? Take an X-ray or an image intensifier, or only when in doubt regarding the position of the implant, whether acetabulum or fever?
Well, in a difficult situation, I think that in difficult anatomies, that's what I normally have available, image intensifiers. I do a fluoro shot, and I take time to actually really have a good projection, so that I make sure that my components are well placed. I mean, we are discussing these X-rays. I was just thinking while we heard the first comment, it really is also relying on the type of approach that you take at the surgery, right? Because what we need at the time of surgery is adequate exposure of the anatomy. And I would think that if we try to be too tight on our exposure, maybe too short, or depending also on the kind of approach we take, it might actually affect the visibility on the acetabulum, but also on the femur. I mean, and this could then lead to a misplacement of the components. I do agree that there is definitely a suboptimal technique of this radiograph here, what we see, and I do think that the cup, from what it looks like, is quite a bit too steep, but I also think that there is a little bit of a problem of malrotation on the femoral component as well compared to the anatomy.
So, Dr. Amr was saying that the position of the cup, this vertical position, might affect the stability.
Again, Ibrahim,
Dr. Amr was saying
yes,
that this position of the cup might affect the stability of the hip. Would you think this might also affect the wear or the behavior of the bearing surface, or would you think this is acceptable, Dr. Klauser? Klauser, you're muted.
What was the question again?
We all agree.
Affected wear, yeah. I think that the wear is going to be significantly affected because you are going to have a more loading on the superior aspect of the bearing, and that is going to definitely affect the wear and the longevity of the implant itself again.
Yeah, particularly if it was a hard on hard, let's say ceramic on ceramic or metal on metal, this would dramatically affect the wear or the longevity of the implants.
Yeah.
Would you think that cup was positioned in that position, or maybe it was placed in a more horizontal position and it ended this way due to the tightening of the screws? Because as you can see, there's a gap or a space behind the lower part of the cup in relation to the medial wall. So would you think that maybe he did not remove the central osteophyte, or it was placed in a proper position and then it changed its position due to tightening of the screws?
It's difficult to swear on that it is getting vertical as you tighten. It is possible. We've seen it happening, but in this case, I think it's just failure to remove the curtain osteophyte or a medial osteophyte. That's my opinion. That he couldn't go in the lower half of the cup as should be. What you said is quite possible. It is a possibility, but I cannot tell from this X-ray.
So do you have any tips intraoperative to make sure that you are resting on the teardrop? What would you personally do to make sure that you are
with the multi-hole? Yes, with the multi-hole cups, it's easy. You can always judge with one of the holes in the inferior half of the cup, just by vision or by probing the hole to the native bone. When you have a closed cup, a hole-less cup, you cannot achieve that. Achieve being sure, that's to say, through knowing for sure that you are touching the bone, because you can't see the bone. And here, the orientation of the cup itself, the orientation of the cup as you insert it, is your judge. Not seeing the medial bone of the acetabulum, that's to say. And again, and again, when you have a situation where you are not sure about something like that, just nip a C-arm and have a look. It will tell you. So you can only swear on it if you have two C-arm images. One with the cup seated very well medially, without the screws. That's to say, an image, for instance, for the trial cup, and another image just like that, with a tight superior and superior-medial part of the cup, while the inferior part of the cup is away from the teardrop. There is something else in this X-ray related to the femur, if you might listen to what I want to say.
Sure, sir.
The femur here, I agree with the Krauser that looks like there is a problem with the rotation of the stem. But I'm here to criticize the preoperative X-ray and the postoperative X-ray not showing the other hip, because it seems like the other hip is as well in an extreme valgus anatomy. And when you have an extreme valgus anatomy, you should really have a high neck cut like the X-ray before this. This is a proper neck cut with the very valgus hips. You need actually to go a little bit higher than that. Otherwise, you will see what you see now, is that you are a little bit short and you need to put a long or an extra long head.
But sir, I think this femur, the X-ray itself, the femur is rotated. So maybe if we internally rotate the X-ray, the femur, maybe we'll have a better view of
this negates the question of the rotation, but it does not negate the question of the how the center of the head is much as superior to the tip of the trochanter like that, okay, which tells you that the other hip is in valgus as well. Once you get a short or a proper neck cup in a valgus neck, you would end in difficulty achieving stability. You'll find that everything is wobbly, and all you can do now is to put longer head and a longer head and a longer head. That's what I mean.
Dr. Amr, I know that you are a big fan of the cauteroplasty in general. So do you have any tips or trips to make sure that you're going medially? Here, as we see on the preoperative X-ray, you have a substantial central osteophyte. So how can you make sure that you have reamed properly? Would you expose the tal transverse acetabular ligament? Would you maybe drill the medial wall and use a depth gauge to make sure that you have, let's say, 5 millimeter or 10 millimeter?
First,
what
I
would
have
you
to
do?
expose the transverse ligament. It's my clue to be sure that I am close to the teardrop. Okay. Second, I use, as I said before, an X-ray. This is only the way I can do with my cup to ensure that it's properly seated.
Mm-hmm.
So the transverse ligament is mandatory. It makes you know where you are.
Okay. So Dr. Klauser, I think that you are mainly a cementless cup surgeon, or do you usually go for cemented cups? I think you're using cementless mainly, yeah?
Mostly cementless.
As far as I know.
Yeah.
So would you routinely use screws?
No, this is a site which is quite unfamiliar to me. I think that it is not a tradition to use screws in a regular case like this, at least in my country. One comment I would like to share is that in my eyes, the cup might have become too vertical because if you look at the preoperative situation, there was a steep cup or acetabular opening anyway. So the surgeon might have tried to actually place the cup in a direction where he achieves the best press fit fixation, and then just drop a couple of additional screws in order to increase that fixation. So instead of doing something like a plasty on the superior edge, which might have become necessary in certain cases or so, he just actually overreamed and then put it in a steeper or more vertical position in order to achieve a sufficient stability for the cup.
Okay, excellent. Thank you all. Any final comments from Dr. Amr, Dr. Taimur, Dr. Klauser regarding this
Yes,
X-ray?
I want to comment on Dr. Klauser, but all what you said, which was what really happened, yes, I know. But still he has a good bone stock. He can start his reaming in a proper positions. That's what I mean. The first reamer is very important.
I agree.
As not my reamers to toggle. So still he has a good bone stock. He can still go in a proper position, but starting from his first reamer.
I completely agree. I think the first reamer should go directly to the center of the acetabulum and then slowly should be taking in the correct inclination. But the first starting reamer is the most important part of the whole.
So Dr. Klauser, you use a vertical reamer first to go to the, would use the reamer in a vertical way, perpendicular to the acetabulum to ream the central osteophyte, or what will you do? How you make sure that you have been achieving the exact position you want to?
Well, there is this way, and then you can also toggle something like curved osteotomes.
Osteotomes and remove the osteophytes.
Take that out and then actually ream in that direction as well.
But what do you personally do?
I take the osteotomes, and sometimes if you have to go fast, then I take the reamers.
Okay.
Push it
so we agree again that probably you have a malpositioned cup. Maybe you have a malpositioned stem. We're not sure about that. So I think that's actually take us to the point that we have to avoid that by doing a few things. We have to plan for that preoperatively. We have to make sure intraoperatively. And if we are in doubt, we can use all the tips and tricks. And finally, if we're not sure, we have to have an X-ray. And I think Dr. Salim is going to explain that in details right now. But, okay, go ahead, please. Dr. Salim. Dr. Salim, you're muted.
Yeah.
Okay.
So, Dr. Ibrahim, all of us agree that there is malposition of these components. We all see that the cup is in a vertical position and there is lateralization of the cup. I think this is because there is a big medial curtain osteophyte which was not properly reamed. That is why this cup was not seated at the teardrop and result in its lateral translation and resulting in this vertical orientation. As regards the stem, I think this X-ray is in severe external rotation. That's why the horizontal offset appears to be too much shortened and the neck stem appears valgus. So all of us agree that templating is a very important issue to make to ensure that our patient will receive the best component position and restore our biomechanics. Templating, whether digital or manual, needs proper X-ray. So our first step to have proper X-rays, we have to take anteroposterior view of the pelvis with the patient supine and the beam of the X-ray centered over the symphysis pubis, and both lower limbs are internally rotated about 15 degrees. Why 15 degrees? To abolish the femoral anteversion and to make the femoral neck parallel to the femoral facet, so the femoral neck appears by its true length and not to be externally rotated. Any external rotation of the limb will falsely decrease the offset and create a valgus, deceiving valgus appearing femoral neck and falsely decrease the femoral canal. That's why you put the limb in internal location 15 degrees. Another important view is the frog leg lateral view to make sure that the femur has normal anterior anterolateral bow. So if there is any deformity in the lateral view, I have to anticipate this and to be prepared properly intraoperatively. Important landmarks on our X-ray after getting appropriate X-ray views are the ischial tuberosity, which is important to determine the limb discrepancy. The teardrop that represents the most distal part of the medial wall of the acetabulum, and the acetabular roof is important to anticipate the acetabular index if this acetabulum is shallow or deep, and to avoid to give us an idea about lateral coverage of the femoral head. Important landmarks on the femoral side include the saddle area, the lesser trochanter, and of course the medullary canal, its width, and the neck shaft angle. And from the femoral canal diameter, I can anticipate if this patient will receive cementless or cemented component according to door classification. After getting these radiographic landmarks, I have to go for establishing the limb length discrepancy using the inter-teardrop line or the inter-ischial line. Yet the inter-teardrop line is more accurate. We draw another two lines parallel to the inter-teardrop from the top of the lesser trochanter on both sides. And the difference between these two lines represent the limb length discrepancy in our patient. In this scenario, we have a patient with 4 millimeter shorter side on the right side. After establishing the limb length discrepancy, I am going to template the acetabulum. And this, as we operate on the acetabulum first, so we template it first as well. Our template should lie on. I'm going to template the acetabulum. Our template should lie on the teardrop, and the medial border of the cup should approximate the ilioischial line and lie close to the teardrop. And the lateral coverage should be identified, the area of the superior lateral edge of the acetabulum, and to detect how much it is uncovered. And the cup should be appropriately placed in an abduction angle about 40 degrees with the inter-teardrop line. The inferior border of the cup should be at the level of the inferior teardrop line and not crossing it. Now, we mark the center of rotation of the acetabular component. And after that, we go for the femoral templating. But before leaving the acetabular templating, there are some tips for us to avoid. So typically in arthritic hips, we have the center of rotation is lateralized, as in the second case which we presented, and there was medial osteophyte covering the true floor of the acetabulum. These osteophytes should be removed and properly reamed to medialize the center of rotation. In cases with protrusion, the center of rotation is reversed. It is more medialized, and patient may need some grafting to lateralize our center of rotation. In dysplastic hips, our problem usually with the lateral uncoverage, and this should be noted and prepared either with bone grafting or metal augments. After that, we go for femoral templating. The first step is to choose a proper sized femoral template that fill the medullary canal. I have to choose the neck angle, a system with the neck shaft angle that reproduce the normal anatomy of the patient. Of course, we have mostly the neck shaft angle between 120 and 130 degrees. Some patients has coxa vara, some has coxa valga. So I have to choose our system or processes to reproduce the normal anatomy of the femoral neck angle. But sometimes this is not usually available, so we may have a neck shaft stem with increased angle in comparison to the normal anatomy of the patient. We mean that the patient has a coxa vara. So in such a situation, we go for, to compensate, we go for low femoral neck cut, and combined with long head, this will restore our biomechanics. On the contrary, with femoral neck, with coxa valga and fixed angle and less than the neck angle of the patient, we can go for high neck cut and combined with short head, This will restore our biomechanics. This can be seen in this patient. She is a female patient, 30 years old, with bilateral AVN due to systemic lupus. She underwent the left total hip. And I think that if we criticize these X-rays, the cup, the abduction angle of the cup is in a good position, and it is not crossing the lower border of the teardrop. And she was scheduled for the right side. We can see that the normal anatomy of this patient, that the neck shaft angle is about 130, 125, 30, 130 degree. So it is in the normal range of the usual anatomy. But unfortunately, we have a design on the left side. She was operated with cementless FMT stem. On the right side, the only available stem was the CLS 145 degree neck shaft angle, and this is much more than the normal anatomy of this patient. To compensate for this, we go for a lower neck cut than the right side. We go for a lower neck cut compared to the left side, and the stem was inserted a little bit more distal than the left side to compensate for this long neck shaft angle, and combined with short head, we can restore the anatomy of the patient and maintain the limb length equality. And the abduction angle is well accepted on both sides. The third step in the femoral templating is the offset. Offset, we usually by offset, we mean the horizontal offset or medial offset, and it is a function of both neck length and neck angle. After we choose our neck angle, so neck length now is the surrogate for the offset of the design. So the neck length for that angle is determined by noting its relation to the acetabular center of rotation. Now, after marking the center of rotation of the acetabular, marked yellow, we have craniocaudal relation of the femoral center of rotation, which will affect the lengthening of the patient. So if it is superior, this will lengthen the patient, and if it is placed inferior, this will shorten the patient. And the mediolateral rotation, medial positioning of the femoral center of rotation will result in increasing offset, while lateral positioning of the center of the femoral center will result in decreasing offset. Combining both inferior and lateral positioning of the femoral center of rotation will result in decreasing the offset and shortening the limb. While placing the center of rotation of the femoral component just inferior to the acetabulum without mediolateral translation will result in shortening of the limb with no effect on the offset. Lateral positioning to the center of rotation of the acetabulum will result in decreasing offset without affection to the limb length, while superior and medial placement of the femoral center of rotation will result in increasing length and increasing offset. Just medial placement of the center of rotation will result in increasing offset without affection of the lower the limb length. In our case, we use for templating, we find that the center of rotation of the femoral component, to correct for the 4 mm shortening, we have to place it superior to the center of rotation of the acetabulum without medial or lateral translation. So we mark the femoral center of rotation to be superior to the center of rotation of the acetabulum and mark our neck cut level, and this will usually restore our limb length. Our landmarks intraoperative may differ according to the approach we use. If we're using anterior axis to the femur, like in lateral approach, we can use the saddle point or the saddle area as a reference for our neck cut. If we use the posterior approach, the placer trochanter will be more accessible, and so we can use it as a mark for our femoral neck cut to reproduce it intraoperatively. In our department, we use the digital templating using the ortho size of Zimmer. And this is an example of a case we do for hair templating. This is female patient with femoral neck fracture, neglected or missed, and she was planned for a total hip arthroplasty. Templating was done on the on the left side, normal side, and the sizing of the stem and the cup, we anticipate that the size of the cup will be 54 and the stem size 7. And there is here a problem or an error that we can, if we look at the template, the stabler template is a little bit high, maybe resulting in this over anticipation of the size of the cup. And the accuracy of the templating may reach up to 90%. And intraoperative, this was created by, we reached our appropriate size to find it 52, and the stem size is the same as in templating. And this is the X-ray post-operative. So templating is very important to anticipate the size of the prosthesis, to anticipate any problems that the surgeon can face intraoperatively. And if there is any variation from the pre-operative templating, this should alert the surgeon that there is something going wrong intraoperative that should be corrected. As you say, that I can look for intraoperative X-ray and can revise my positioning, the position of the prosthesis. And all these things should be put into consideration so that our patient get the maximum benefit from this operation. Thank you.
Thank you, Dr. Ahmed. Excellent presentation. Would you please care to put go back with the slides a little bit? The one with the a little bit the one with the femoral and acetabular center of rotation. Because yes, just leave this any one of these. If you want, to make sure that everybody understand this, what we're putting for real, just leave anyone. No. Just leave with the one with the center of rotation and center of rotation. Yes. What we're putting for real is that the acetabular center of rotation. That's the one we're using for real. That means if we mark the center of rotation of the acetabular, that's the patient center of rotation, and we compensate for any abnormality in the femur by templating at a different point. يعني بنحط center rotation of the acetabular وده center rotation بتاعنا، والcenter rotation of the femur. لو قلنا مثلا العيان قصير سنتي، هنعمل templating فوق الcenter rotation of the acetabular بسنتي، صح يا احمد؟ That's what you mean. يعني we compensate for، يعني لو center rotation of the femur محطوط فوق center rotation of the acetabular حوالي سنتي، intraoperative احنا بنريديوس ده على ده، فمعنى كده ان احنا هنطول العيان سنتي. فلو احنا عندنا سنتي ونص هنحط السنتر روتيشن اوف ذا فيمر سنتي ونص above السنتر روتيشن
ده عن طريق ايه يا دكتور ابراهيم؟
التمبليتنج بتاعنا.
عن طريق ايه بقى؟ عن طريق ايه برضو عشان اوصل لايه؟ وصولا للكات بتاعي.
وصولا وانتر انا بمارك الليفل اوف ذا كات وبميجر انترا اوبريتيف برضه
بالظبط كده.
يعني
بس الناس اللي سمعانا تبقى فاهمه وصولا تو ماي كات. الكات ده لما بناخده عشوائي بينتهي بحالات فيها انستابيليتي وفيها ليج لينس ديسكريبنسي. دي اهميه التمبليتنج القصوى، ان انت مش كل 10 حالات يطلع لك حالتين 3 فيهم ليج لينس ديسكريبنسي وتعاني مع المريض بعد كده.
اتفضل. مهم جدا برضه يا دكتور احمد that you have to mention that you can do this digitally or manually
or overlay method.
Yes, if we're doing it manually, you have to make sure that the magnification is proper because we have different.
The most accepted magnification in most of the centers about 15 to 20%.
And you have different magnification templates and most of the companies. And you can change the magnification by asking the radiology department to put the magnification 10, 15, or 20, right?
Yes. Of course, and okay. Our magnification marker should be, just to mention, that should be at the level of the joint, of the hip joint, in the lateral view and the anteposterior.
What do you mean by magnification marker?
Coin.
أو في ماركر مخصوصة بنلزقها على الجلد عند الهيب بالظبط عند
at the
lateral edge
level of the hip joint.
Exactly. Any comments from the panel? Dr. Klauser, would you like to comment on that? Do you have any clarification or comments on the templating?
No, I think it was a fabulous presentation. I think what needs to be understood also is that there need to be made some compromises at the time of surgery, because sometimes you need to actually stop reading even if you try to get the best position of the cup, because you're going to actually break through the subchondral bone, and then you're going to get into the softer cancellous bone. So this is a great rule, and it's didactically speaking excellent, but intraoperatively you just need to look how well your bone is, and if you are going to not ream away too much bone. So be sure that you understand the principle of planning, but you're also sure that you actually don't destroy too much good bone.
Dr. Taimur, I know that you're one of the very first at our department that taught me how to template. You were drawing the hip using the cut paper, and I do remember that a long time ago. Would you care to comment or maybe have any extra tips for that?
I wouldn't actually. I use the orthosize regularly now. Despite the limitation of the types of stem that it has, it's a good all over very simple templating software. I wouldn't rely too much on on this bit of going up and down and going medially and laterally from the template alone. I would have it in the back of my mind, and in these situations, I think the intraoperative stability, the length is a little bit tricky during the operation, but the stability and the good facing, the combined antiversion, that's to say, a good combined antiversion of Ranawat and a good stability and a good range of motion without any dislocation is about what I can get from templating. The issue of adjusting length just by having a look on the template, it didn't work well for me, because usually the cuts that I am having on the template are not the cuts that I'm having in the operation. And again, I rely as much as I can on clinical basis and tension. Yes.
So, sir, correct me if I'm wrong. Your first priority is the stability of the hip, and for that you control the position of your cup and your stem, also your soft tissue tension. How can you make sure? How you can make sure? I know that you're operating in the lateral position. How
exactly.
Sure?
That's it. We are in the lateral position, and we are doing direct lateral approach. You know, not every approach is amenable to every trick.
How can you make sure that your leg length quality is good?
Yes, this does not mean that these 5 or 6 successive slides are not important. They are extremely important, but not important for me to help me too much in tweaking the operation. It is of utmost important not to follow them, not to do that, you know, not to go inferior and lateral too much. And you know that if you go inferior and lateral too much, you're going to decrease the offset, and you're going to shorten the limb. You know that what you do is going to do that, and you can see it in reverse. If you see that you have a short limb, too much short limb, and a too lax lateral pull, you might then revise yourself on where the center of rotation is. It is inferior and lateral or not. So the 6 combinations that are shown in this presentation are very good and are very helpful. In my opinion, or in my hands, they are very helpful because they tell me not to fall in these positions.
Amr is operating in the supine position, as far as I do remember, and you don't have the problem of making sure that equalizing the leg length is a major issue. So, do you have any tips for that, Dr. Amr? You are usually operating in a supine position.
I use using Jones make me can apply my templating very easily. Actually, I have no problem with length discrepancy because it is very easy to apply your templates on the patient while in supine position. But anyway, I want to repeat to all our audience, it's very important to avoid this major problem with limb discrepancy, is to do templating and always to have a conservative cut. Don't go far down with your cut to make things easier for you. Try to have a conservative cut to have a chance to correct yourself and to retain the neck, which makes a very important issue with the rotational stability, which you can gain longevity for your implant.
So Klaus, would you use special calipers to make sure that the leg length equality is perfect?
What I sometimes do is I take Steinman pins and actually place one into the tip of the greater trochanter, and the one is in a fixed and defined position on the supraacetabular region. And then there's a little metal chain that connects both of those Steinman pins. And then while you restore the leg length, you can actually double check if you actually increase the leg length or not, or if you increase the offset, because the chain is going to actually help you to actually judge the distance between the two Steinman pins. And if you find that severely modified, you know that you're severely off. So that's something that actually helps you to do that.
But you don't do that routinely in some of your cases?
No. It's also a question of soft tissue, attention, and also stability of the hip.
Okay, maybe you can take a couple of questions, but before that, Dr. Ahmed Sobki was raising hand. Our Dr. Ahmed Sobki, I'm not sure if he's still here or no. Are you still with us, Dr. Ahmed? I cannot see him, sir. Dr. Ahmed?
Yes, Ibrahim.
Dr. Ahmed Sobki. Okay, I cannot allow him to talk. I'm sorry. Okay. Please, if you want to ask question, use the question and answer, not the chat box. We have a few questions from Dr. Abdullah Nada. I would like to understand the relationship between the neck cut level and the neck shaft angle, varus or valgus, after placement. Ahmed, would you care to answer that, please?
The neck cut is related to the will be determined according to the center of rotation of the femoral component. And to determine our center of rotation of the femoral component, it is a combination of both the neck angle and the neck length. And as we said that the offset is a combination of both. If I have the possibility to choose our stem that will reproduce the normal anatomy of the patient, so I have no problem. And now I have been left with only the neck length. The neck length will be determined according to the discrepancy of the patient, so that I can go for marking the femoral center of rotation. If I have no discrepancy, so it will be coincide with the center of rotation of the stem. If I have shortening, I should go superior to that. And how can I go superior end at the level of the femoral acetabular center of rotation? I go with the template, femoral template, up and down to determine the level of insertion of our stem. And once I restored the length and offset, I will mark my femoral neck cut.
Okay, we have another questions. What
ممكن يا ابراهيم بس انا عايز ارد على الدكتور عبد الله عشان اخلي الامور اسهل بالنسبه له to make things easier as far زي ما قال الدكتور احمد سالم. يعني يا دكتور عبد الله في الفالجاس نيك long neck usually have a يعني conservative cut and short neck prosthesis. On the contrary, with a varus femoral component, or femoral femur, you have to go for to go with your cut sew down and to have a long neck. This long neck prosthesis. I think Ahmed انت شرحتها clearly in a slide, and this will make things easier for our audience.
What are the danger of total hip replacement in ankylosing spondylitis, Dr. Clauser? What do you think? Do you have any tips for that? Patient with ankylosing spondylitis, do you think that they posed certain dangers?
Yeah, well, I think that the problem is really that of course, you have a problem with the lumbar spine, which is going to then be fixed in a certain position, which might then put a greater risk at your cap anteversion. Basically, that might then lead to a false impression at the time of surgery, which then could lead again to a higher risk of instability of the hip.
So how can you avoid that?
Well, the thing is really that you actually, I mean, I think you should position the patient yourself, and in order to make sure that you get the best possible position. And then you should actually make sure that I'm doing all my cases in a lateral position, in the majority of cases at least. So I don't have an issue with actually placing the lumbar spine and the pelvic tilt in the correct position when I put my patients in the lateral position, so that I can appreciate and anticipate the proper orientation of the acetabulum.
Thank you very much. Thank you, Dr. Ahmed Salim, for excellent presentation. Would you please care to stop sharing? And Dr. Haitham, stop sharing. Haitham, are you ready? Dr. Haitham.
Yes, I'm ready.
Ready? Please share your screen.
Yeah. Thank you, Professor Ibrahim, Nathan, Professor Amr, Professor Taimur, Professor Clauser. Now I'll start the second session, which is how to choose the best implant for each patient. Here is our first patient, a 70-year-old lady with Parkinsonism with a right femoral neck fracture. Here, the main concern should be stability. In this patient with many risk factors for dislocation, as being a female at old age with neuromuscular disorder, which is the Parkinsonism. So we have to minimize the surgical risk factors for dislocation. So how to improve stability?
Dr. Haitham.
أيوه.
البانل. البانل. ارجع تاني. طب احنا هنا we're presenting صح 70 years old female patient عندها باركنسونيزم. زي ما انت كنت بتقول في السلايد اللي بعديها ان احنا عندنا variables كتير قوي. We're talking mainly about stability. ممكن نجيب السلايد بعديها دكتور هيثم؟
Okay. Here are the risk factors, meditation
Would you
factors
comment on
or surgical factors.
In each of these factors, she's a female patient. That means that we have a higher incidence of instability.
Yeah, a female patient has higher incidence because of their less muscle mass and weakness. The age is another factor. Of course, any neuromuscular disorder, as the previous strokes or Parkinsonism, as in our patient. Cognitive disorders and following the instructions post-operatively. Alcoholism, prior surgeries, or abductor weakness.
كل ده patient factors.
The factors,
these are the patient factors that
we cannot control. We are not controlling.
Are not modifiable, most of them. Maybe you can stop drinking alcohol, maybe you can do some exercise, but most of these factors are non-modifiable. The other factors, which are the surgical factors, maybe are a bit modifiable, right?
Yeah, we should modify to compensate for patients.
Surgical approach.
Professor Ibrahim?
Yes, okay.
The surgical approach is the first one. Capsular repair, to do repair or not.
So can you stop here a little bit? Dr. Taimur, would you think that the surgical approach, I know that you are supervising a thesis or a multi-analysis, a meta-analysis regarding the surgical approach. If you do remember, comparing the anterior and the lateral and the posterior approach. Would you think the surgical approach would really affect the stability?
Yes, the stability issue is always thought, and it is actually as from the unstable side to the stable side is posterior to anterior. It depends on the side or the direction of the location. With the newer exposures of the direct anterior exposures going into the high stability issue. The main culprit here actually is the surgeon's versatility. The surgeon who is doing posterior exposure all the time is probably going to have less dislocations than a surgeon who is doing other exposures, say lateral exposures all the time, and will venture on posterior exposure once a month or once every 3 months or once a year. So I would raise my hand here for some surgeon who is not doing a posterior exposure to do a posterior exposure in a patient with suspected instability issue. I think this is a statement that will never go wrong. If you are not a posterior exposure cap, don't do a posterior exposure in a patient with instability issue.
So sir, you're saying that most of the approaches are not really affecting the stability rather than the surgical experience. Am I understanding right?
No, the surgical experience is in one hand, and the exposure itself is on another hand. The posterior exposure technique, going into a fast answer actually, because it's a big issue. Posterior exposure technique without damaging the capsule or with capsular repair is different from the posterior approach with capsulectomy, for instance. The issue of which direction is the hip dislocated, I think, is the issue. The less known exposures for dislocation are those with the anterior exposure, including the direct lateral approach. As I told you, the newer ones with the pure anterior hip exposures. So if you have an issue for instability, it's better to do something else than the posterior approach, especially if the instability is related to the ability of the patient to sit up and down, and is related to the muscular contraction of the patient. That's to say that this group of patients who are either Parkinsonian syndrome or post-stroke. I think these patients are better given a total hip through a lateral exposure or an anterior exposure.
Now, sir, I know that you are mainly a posterior approach surgeon, as far as I do remember. Am I right?
Yes.
We're going into a big debate now.
No, I'll try to avoid that debate, but I'll just go for a straight question. Would you do posterior capsular reconstruction or repair in every single patient? And you think this might affect the stability later on?
Well, I think that this is a theoretical debate, because it's been proven in the literature, if you do a capsular repair in the posterior approach, then you're going to decrease the amount of dislocations. So this is a must for all of my patients.
Totally agree, yes. So as far as I do remember, it was, I think, Pellicci who published this, and it decreased the rate of instability more than 10-folds, as far as I do remember. And as far as I do remember also, Dr. Taimur, your meta-analysis thesis, the conclusion was that the posterior approach was one of the least susceptible to instability. Yes. I think that Dr. Amru will not agree with that, because Dr. Amru is mainly an anterolateral surgeon.
My policy is to spare the abductors. have a soft tissue tension, yes, but to spare my abductors. I will never have a limping, or I will never have the issue of instability unless there is component malposition.
But sir,
so I think sparing
posterior...
the abductors, I do believe that capsular repair in posterior will improve your results. I do, but I do believe also that when you are above the abductors, working above all this issue, I think that you have a very stable joint and you'll have no limping whatsoever. So I believe in my simple cases, I'm not in need to go for posterior reconstruction. It's an ideal to go for an anterior or anterolateral approach.
Actually, it's quite interesting, but it's just a mere coincidence that our three panelists, Dr. Taimur is mainly a lateral approach surgeon, Dr. Klauser is mainly a posterior approach surgeon, and Dr. Amr is mainly an anterolateral approach surgeon. So we can.
What about our moderator?
I'm unfortunately a posterior approach fan.
So
posterior.
Yes.
I will not.
Posterior.
Yes, posterior.
I will try not to hate you.
Unfortunately. And I think that the incidence of instability with the posterior approach have been misunderstood all through. I think the incidence of instability is much less than anticipated. That's my own belief. But Dr. Amr, I'll go back to you again. Putting the cup in proper position is usually a dilemma in the lateral approach or in the lateral position. Maybe most of us are not really acquainted of positioning of the cup while the patient is supine. So do you have any tricks or do you think any comment regarding that position?
I think in the supine position, you never have a problem with the cup. Cup is very easy to settle in the angle you need exactly. Sometimes you have a problem in obese patients with the femoral components. And this requires to modify your approach or the Jones approach to go with your vertical limb proximal, a little bit proximal to the trochanter, and then go for your other limb distal to the trochanter in order to have the greater trochanter, the GT, inside your approach, to have a better, easier to seat your femoral components. But for the cup, I think I have no problem at all to have my cup reamed and seated in the way and in the angle I need to put it.
So we all agree that the positioning of the component, particularly positioning of the cup, will affect our post-operative stability, and that's why we need to do every effort possible to avoid that. So Dr. Haitham, would you care please go back to the X-ray and ask the panel what's their preference regarding this patient, starting with Dr. Taimur.
Yes, that's okay.
Raisam, would you please go back one slide? It's not moving. It's not moving. Stuck.
Yeah, stuck.
Okay, this is okay. Till you fix it, this is 70 years old female patient, Parkinsonism with a femoral neck fracture.